First of all, thank you very much for your compliments. Being a clinical oncologist is very rewarding in that we can follow up the patients from the diagnosis, which is very bad news for most patients, and follow them through all the treatments and also the sufferings in terms of the psychological impact, social impact, and also, of course, the physical discomforts that have been caused due to either the treatment's side effects or from the disease itself. And of course, some patients are fortunate that they can recover from the cancer, but inevitably, many patients may have some benefits from treatment, but eventually they also have a disease progression. And at some stage, some patients really have to accept the fact of life that their disease is not curable. And at that time, we'll focus more on palliative care. But we are still with the patients. So we basically we follow them through, walking with them, and we learn from them basically, because we ourselves have not passed through this difficult journey of life. So it's good lessons for us as well. Our research nowadays is quite standardized, and we have all the guidelines like the ICH E6 to set the standards for the ethicals and also the other important aspects in maintaining a standard of clinical research. I think the challenge nowadays is that how to recruit adequate number of patients for trials, because we have so many competing trials. Undoubtedly, immune checkpoint inhibitors is a breakthrough, and as you can see nowadays, I estimate that more than half of clinical trials in clinical in cancer involves immune checkpoint inhibitors. There are advantages in that immune checkpoint did have a very good response, and also quite a durable response in a subset of patients. But honestly, more than half of patients do not benefit from immune checkpoint inhibitors. So I think we should go to a higher level of immunotherapy, in that such treatment will also benefit other patients who did not benefit from immune checkpoint inhibitions, either that the tumor doesn't the tumors have other mechanisms of evading the immune system, and maybe their immune system itself is not intact, and also other unknown factors as well. The understanding of our immune system is still incomplete, and there are many facets in our immune system in which we can explore further and to develop new treatments. So in general, I think immunotherapy is our hope of dealing with cancers because it has a memory effect, and in general, because of this memory effect, our immune system theoretically can cope with the changing clones of tumor cells. Because as compared with targeted therapy, most targeted therapy can only have a temporary effect, and after which drug resistance usually develop. But theoretically, our immune system can adapt and also to cope with the changing genetics of cancer cells as the disease evolves. I think we are now at a turning point in the history of cancer management. In this new era, we will see that the practice of oncology will be quite different 10 years from now. So we need the patients and also clinicians as well to keep themselves up to date about the new developments. And with this, the time between the discovery of this new knowledge and the application to actual clinical practice can be shortened, so more patients can benefit from these advances.